Welcome, ladies and gentlemen, to the Inquisitive Introvert podcast. I'm joined today by Krishna, who is the Vice President of Health Data Exchange here at Blue Cross Blue Shield. Krishna, I wanted to speak with you for a few different reasons. I feel like you have a really interesting story and background, but I actually wanted to get your input on some of the things that are going on in the healthcare industry. Before we get into that, we should probably let people know how we met. So actually, we work here at Blue Cross Blue Shield, and you were one of my instructors for my master's degree in biomedical informatics. So that's kind of our background. I really enjoyed your leadership in that class. It was fun. One of my favorite classes I've taken thus far. So Krishna, just before we get into the hot topics, I kind of want to know a little bit about your background. Just briefly, kind of let us know where you're from and how you got into the industry.
Cool. No, thanks for having me. Always excited to talk about healthcare and data and technology. So I grew up in southern India, a place called Chennai. It's in the sort of southeastern part of the Indian peninsula. So I came to the United States about 20 years back for graduate school. I went to UIC. And then that was actually when my sort of introduction to healthcare actually happened. Part of my master's thesis was on sort of using digital signal processing techniques in order to separate out heart sounds so we can sort of localize where a murmur was happening or what part of the heart had sort of a problem. And so it was sort of my first sort of introduction to sort of healthcare and using technology and engineering principles there. So it was a neat experience. Now, from there, I went to Epic, which is a leading healthcare IT provider up in Madison, Wisconsin. So I was recruited off campus, and I joined as an entry-level sort of technical services engineer, and then had a chance to work on many sort of healthcare systems. There are sort of Epic EHR installs across the country. I got to work with Cleveland Clinic and Geisinger and DataCare up in Wisconsin and in the Chicago area with like North Shore, Rush. And so it was really cool to get a sort of a front row seat to how technology is implemented and used in health systems. From there, I joined DuPage Medical Group. So I wanted to get closer to where care was delivered and how I can make an impact. I loved what I did at Epic, but I felt as a technology provider, I wasn't directly sort of shaping how care was delivered. So I joined actually an Epic customer called DuPage Medical Group. They're a large independent provider group in the western suburbs of Chicago. And it was really cool. I had a variety of roles. I led their transformation efforts on what they called value-driven healthcare, so a movement from fee-for-service to value. And this was 10 years back, like well before sort of fee-for-value or value-based care was even a thing. So it was really exciting to see such a forward-thinking physician group want to sort of tackle that. So yeah, I spent 8 years, variety of roles there, and then came to the payer side. So that was sort of I've been with Blue Cross Blue Shield for about 18 months now. So it's sort of my background and healthcare journey so far. So
super fascinating. So along with that, Krishna, one field that has emerged out of all this data talk is health informatics. And it's a variety of different sort of definitions out there. But what is your definition of health informatics, biomedical informatics, bioinformatics, everything that's listed under the umbrella?
Yeah, no, great question. Yeah, I was talking to actually somebody just earlier this week about it. I'd say for me, maybe the simplest definition for me, what I love about sort of health informatics, bioinformatics is it's sort of the intersection of sort of data, technology, medicine, and it's a sort of a unique confluence of these three fields. And obviously there are so many sort of opportunities in delivering meaningful, actionable information sort of in workflow, whether it's where care gets delivered or where the sort of our providers practice. And there's an art and science to it, how information is presented in a way that can be acted upon, how information can be sort of distilled in a way that is sort of meaningful and useful and contextual. Lots of opportunities, and I think particularly one of the things that excites me about that is it is such a sort of multidisciplinary field, both art and science sort of combined into it. So I guess that's how the simplest way I've defined it. Yeah.
Oh, sweet. So one question that I have, Krishna, and I think a lot of people might have this question is, why was healthcare so late to the game in terms of data integration and sort of understanding and analyzing patient information? I feel like, you have it in different industries, whether it be music or entertainment, that have kind of latched on to data, but healthcare has kind of been a bit behind.
Yeah, great question. I think healthcare has always had these sort of pools of data that didn't always cross. I think we've had the pharma pool, the payer pool, the provider pool, the sort of the patient reported pool. So we've had these sort of distinct sort of collections of data in various stages of maturity. Like not every data was sort of robust, and clearly they didn't have a reason for these sort of pools to actually sort of intersect. And that's changed quite a bit. I mean, I'd say even the last sort of, like 5-10 years, the longest standing pool of data is probably of mass data has largely been in the data you need to get paid, like, what comes in a claim. And so that's been, I think, a rich source of data there. And then particularly with sort of federal incentives to incentivize sort of provider hospital adoption for EHR, we have a very rich and robust pool of sort of clinical data in the walls of hospitals and physician groups. And if you see some of the statistics of meaningful use, it's quite impressive, the sort of coverage we have there. We're obviously also having a growing set of patient data, largely sort of Fitbit and health kits and some of those sort of aspects there. It's a lot of noise in the data, but certainly higher volumes of data. And we've always had sort of, pharma data, largely from a clinical trials perspective there. Interestingly, we've had many sort of data silos and particularly regulation, the pressure to sort of go to more value-based care, the pressure to make care more affordable, bend the cost curve. It has been sort of interestingly forcing functions for these various pools to start to sort of interconnect and crisscross and send data back and forth. And so we're sort of at such a fascinating time in I think, the history of data in healthcare and we have sort of whether it's regulation, whether it's aligned incentive contracts, designed to sort of further the movement of data. So I'm excited there, but it's going to take us some time, right? Like it's even with meaningful use, CMS even last year was starting to pivot to, they incented the collection of data and the installation of systems, and now they're sort of even pivoting to sort of what they call promote interoperability. How do we make sure that the collections of data, even in provider settings, are actually interoperable and talking to each other to sort of provide benefit and care delivery. They also sort of proposed certain rules earlier this year on just how do we make that sort of data transfer happen between providers to providers, providers to payers. And so it's an interesting space that I think we'll continue to see more activity on. I expect more of that happening even in the patient community.
Okay.
Many of the rules are largely around member providing consent to move the data around, or sort of the liberation of CMS fee-for-service Medicare data via sort of blue button. So it's an interesting, sort of movement from a regulation perspective, particularly to have these sort of pools of data connect. And I think we're going to see more and more of that, in all of these dimensions, including sort of as pharma and value-based purchasing of drugs and outcomes sort of continue to become true. I think we'll see more of that. We've unfortunately had to play catch up, and you're right. There are industries that, like the financial services, for instance, they've almost had to interoperate to move funds and the EFTs in the process, and so they've had some sort of head start, and I think we're have to play catch up. But obviously, it's an exciting time to be in healthcare because all this is happening.
For sure. One question that I had, Krishna, that maybe this is a silly question, but why do we have various EMR systems? Does it strictly boil down to money? Because I know certain EMR systems you pay I don't know, X amount of dollars and it's limited to a certain amount of functions? Or is it mostly because the processing of data is so complex that you need, I guess, various vendors to process whatever information is out there? Or is it like a kind of a money game, or both?
Well, I think I don't know if it's necessarily the need to have many vendors or a money game there. I mean, it's just that's what happens in a competitive capitalistic economy, right? We have multiple ways of solving certain problems, and we determine the market. The market determines sort of the winners and losers there. And so EHR, like any technology or any sort of services, right? Like, I mean, you have many grocery stores to pick from. You have many banks to pick from. You have many, sort of ride-sharing options to pick from. And so it's just a pure sort of that's what it means to be in an economy. You want to have multiple players. You want to have multiple sort of options to pick from. And so that's why multiple EHRs exist. I would say, particularly, with the requirements for certification and some of the what it takes to sort of meet all the requirements that came via meaningful use, it did make some winners and losers sort of things. I think it sort of shrunk the playing field because most companies had to do a lot to sort of meet the requirements. And it's still, I think we still want to promote competition, but that's a core of what America is. But at the same time, we want to create some consistency and some standardization, because we want, particularly we want these systems to truly be interoperable. We want, just like, Bank One can send some money to Bank Two, even though they may have different core systems, we still have sort of a standard of sort of money transfer. Interoperability is trying to do some of that, create a sort of framework by which data and data elements move through, but still not do so in a sort of a pro-competitive sort of manner there.
Sure. And kind of along those lines, Krishna, one thing that we have been hearing in like the political space is that this is medicare for all sort of guarantee, and in a capitalistic society, which America has pretty much always been. Is that like a realistic promise? I mean, I know it's more of a political question, but I personally don't think it's in our values, intrinsic values in the states, to be sort of a Medicare for all type country. So do you kind of foresee that happening, or is the insurance company too big to kind of be taken out or removed from that process?
A great question. I obviously there have been sort of many flavors of this over the decades there as well. I mean, interestingly, Medicare itself isn't one entity. I mean, Medicare, a good chunk of just Medicare is outsourced to commercial payers via Medicare Advantage, and so the CMS as a sort of a payer has their fee for service that they administer, and they certainly encourage sort of public-private partnership for even their members in the process. So Medicare for all doesn't necessarily mean that there will just be one payer or one sort of administrative body working on how sort of care gets financed and sort of networks get built in the process. But it is there is, I think, more work to sort of define what that really means, and what it means from a sort of a competitive insurance companies that are sort of in the private sector too. Largely, my sense is, just given sort of the ethos of our country, you'd want choice. You'd want to you would want to have sort of competition. Likely the CMS is lean, just like it has been for decades with Medicare Advantages. We'll want our sort of constituents at large to have sort of choice, and so I think that'll probably continue, would be my sense.
Okay.
Obviously, there is a different question on sort of coverage, and is there ways we can create coverage for sort of the uninsured, and is sort of quote unquote Medicare for all a way to expand coverage for people that don't have coverage, and that's a different question, right? It's a question of access to insurance as opposed to who administers insurance or who builds and manages networks. And so depending on how you sort of define it, I think there's some, we ideally would want every American to be covered by some insurance, and people don't go bankrupt because they don't have access to good insurance there. I think that philosophy of, for all makes sense. but how it gets sort of administered, how
Yeah.
it sort of plays out. I think we'll have to sift through what is rhetoric and what is sort of reality there, and figure out how it sort of lands in the political cycle.
And Krishna, I know you're busy, so just a couple more questions. Moving away from kind of the details of healthcare, I want to know why do you teach? You already got so much going on. Why add an extra job to your day?
Great question. It's interesting. I've been as I think through the 24 hours I have in a day, and I think it's been interesting. I want to sort of make sure I'm prioritizing my time on just activities that sort of help me grow, help me learn, and help me sort of contribute to the sort of the greater common good. And so whether it's one of the things I love about working for a payer like even Blue Cross, I think, is the opportunity to make an impact for the 16 million members we serve. Like, how do we sort of shape how we deliver value-based care? How do we make care more affordable? How do we sort of influence sort of payment models so that we can influence and incentivize sort of models that reward on better outcomes and better sort of clinical effectiveness for our members? So it's a cool opportunity to sort of shape how healthcare gets delivered. And so that sort of theme extends to, whether I spend time with sort of the nonprofits I support or teaching. It's how do I, it's such a unique opportunity because teaching, I think, keeps me always on my toes. I'm always learning, whether it's because it's such an evolving field, B, students like you are asking questions, sort of keeping me on my toes. So I'm always learning and researching about a topic. And I think it's such a unique opportunity to sort of help, shape and sort of work with the sort of the next generation of leaders. And I've said this to you in class and others as well. I'm so excited that people are sort of on the bus with me, wanting to sort of solve the challenges of tomorrow, and the more sort of bright people that are sort of willing to learn and understand the complexities of our healthcare system and want to sort of understand all the levers and all the data, all the technology, how the models are set up, is to help sort of solve for a better tomorrow for all of us. I mean, how cool is that?
Yeah,
and teaching gives me sort of access to your mind share and keeps my mind fresh, and it's such a cool responsibility and opportunity and a blessing to sort of help sort of craft that the leaders of tomorrow, which is so exciting because I need all of your guys' help in order to solve our healthcare problems.
Awesome. Well, I enjoyed your class, Krishna. And my final question is, you are leading our book club this year.
Yes.
I'm sorry, this quarter. And the book that we're reading is American Sickness. So, what is your favorite book in general, and why?
It's interesting. That's actually one of my favorite books.
Oh, really? Okay.
It's a really cool book, particularly around it. I don't know if you've started reading it
Not yet.
Yeah. I'll yammer about it so people can start it too. What I love about it is it's a really good sort of education on all the stakeholders that exist in healthcare and sort of their own sort of incentives and why the system is the way the system is. And I think truly for sort of change makers and people that want to sort of improve the system and make this sort of better outcomes and more efficient, we have to understand why the system is the way it is. We have to respect the legacy. We have to understand what about how it is sort of structured, and what are the players and their incentives and their drivers for us to truly make change in the system. Oftentimes we have people on the outside that are just like, oh, this is crazy, just like fix it. It's like, well, like if it was. If it was somebody could regulate our way, somebody could sort of magic wand our way, it would have happened, right? If that was so easy, it would have happened decades back. And so understanding the complexity of the system is step one, and the American Sickness is a great sort of book to help sort of understand why is it the way it is, who are the players, what makes the system the way it is. It's also got some sort of interesting sort of practical tips on how to sort of work the system, work with the system, sort of understand it, and so you're more aware. The other book that has always been a favorite for me is a book called Switch. It's about making change happen when change is hard, and it's written by two psychologists, and really cool book on just the behavior of humans and what it takes to make change happen. So really cool book as well. And I think I'd say those two, and understand the system, and then all the tips and tricks on how to make change happen, I think is a good sort of compliment as well to read.
It's a good pairing. I have to check it out. Well, thank you, Krishna. I really appreciate it. Hope you had a good time, and I look forward to seeing more of what you do. You're always running around in nice suits in the company, so
thank you.
I appreciate it.
Yeah, no, happy to help, and thanks for having me, and always a pleasure.
So. Oh, no problem.